We are live.
Good evening, everyone. A warm welcome to everyone to today's iFocus online session. Today is 15th Refractive Surgery module. Today we have a topic, surface ablation techniques by Dr. Amita Koul, ma'am. We have Dr. Kanika, ma'am, to moderate today's session. Ma'am has finished her MBBS, DNB and FICO. She's finished her MBBS from Government Mohan Kumara Mangalam Medical College, Salem, Tamil Nadu. DMB from iCare Hospital, Noida. Fellowship from Center for Sight, New Delhi. Currently, ma'am is an associate consultant in Center for Sight, New Delhi, involved in training DNB and PG students and mentoring fellows. She's involved in iFocus training program as well. She's a recipient of multiple awards for Best Video, Best Paper, Best Poster at AIOS, DOS, WOS, SAO, and various conferences. She has received Young Researchers Award for her thesis. She has multiple publications on cornea, cataract, and refractive procedures in various national and international journals. Welcome, ma'am, and over to you for the introduction of our chairperson, Dr. Chitra, ma'am, and our speaker, Dr. Amita Koul, ma'am.
Thank you, Kritika. Next slide, please. So it is my immense pleasure to introduce our chairperson for today. Unfortunately, ma'am is stuck somewhere in traffic. She'll be joining us shortly. So Dr. Chitra ma'am is the medical director of the Eye Foundation, which is a chain of 20 eye hospitals in South India, and they've recently expanded as well. Ma'am is also the president of Coimbatore Society of Ophthalmic Surgeons. She's a very well-known name in the field of ophthalmology in India. She's highly proficient surgeon, anterior segment surgery such as cataract, glaucoma, and a pioneer in refractive surgery. She's been doing refractive procedures since 1997, and she also has the distinction of conducting innumerable instruction courses both India and abroad, including in ASCRS, APIO, APACRS, and even ESCRS on a regular basis. Ma'am has many papers to her credit, and she's even authored multiple books. She's held very important posts in the past. She's been the chairperson, Academic Research Committee of AIOS from 2020 to 23. She's also the member scientific committee of AIOS in 2017 to 2020. Ma'am has also been the chairperson, scientific committee of Tamil Nadu Ophthalmic Association and past management committee member. She has various accolades to her name, and I think if I keep elaborating, we'll finish this class just by ma'am's introduction. We have a speaker today, Dr. Amita Koul. Next slide, please. So, Dr. Amita has done her MBBS and MS from Government Medical College, Jammu. She has also completed her fellowship from Rajiv Gandhi University of Medical Sciences, Bangalore. She specializes in cornea, cataract, and refractive surgeries. Also, she has comprehensive experience related to ocular surface disorders and their management. She's been trained at Narayan Netralaya, LV Prasad Eye Institute, and Sankara Eye Foundation, all premier institutes of India. The ma'am has more than 11 years of ophthalmology experience, and she's currently a consultant at Center for Sight, New Delhi. More than 20 peer-reviewed publications and delivered multiple lectures in national and international conferences. We welcome Dr. Amita, ma'am. And over to you, ma'am, for today's interesting session on surface ablation techniques. We all know surface ablation has stood the test of time, and it is still practiced widely. Over to you, ma'am, now.
Thank you so much, Kanika. I'll be sharing my screen. Is it visible?
Yes, ma'am.
Yeah, thank you for the kind introduction. It's an honor to be presenting in a session being chaired by the one and only Dr. Chitra ma'am. And today I'll be presenting on surface ablation techniques. So, emmetropes have sought various ways to improve their vision for more than a century. Now, attempts to design the ideal refractive surgical procedure to reduce emmetropia has challenged some of the greatest minds in this field as early as 1898 when in Netherlands there was this scientist Lance of Leiden. He gave the concept of keratectomy, keratotomy, and thermokeratoplasty, and he was the first one to describe these. In theory, when we look at a refractive surgery procedure, the ideal would be a procedure which is simple, effective, minimally invasive, safe, stable, and of course widely applicable, and would be able to correct all refractive errors. It should also be adjustable and reversible, and probably also allow a continuous visual correction and a recovery with a minimal discomfort. And it is in search for this ideal that we have evolved from procedures like conductive keratoplasty to individualized and customized treatments, which we now do using various different methods. At present, we have discussed in previous classes, it is excimer laser photoablation, which is used for a surface ablative refractive surgery procedures. And we also know that photoablation occurs because cornea has an extremely high absorption coefficient at around 193 nanometers. A single 193 nanometer photon has a sufficient energy to break the carbon-carbon and carbon-nitrogen bonds, and the essential structure of corneal collagen helices is formed by these bonds, and this is actually the peptide backbone of the corneal collagen, and this is broken down by these photons. And excimer laser radiation ruptures therefore this collagen polymer into smaller fragments, and a discrete volume of corneal tissue is expelled from the surface with each pulse of laser that we give. So initially, when we started using excimer laser, investigators were more interested in knowing whether this laser could actually be used like a scalpel to cut for assisting with corneal surgery, like in procedures which we used to do at that point of time when we started doing all these procedures like astigmatic or radial keratotomies. But the excimer laser was found to be a very poor replacement for a cutting blade or a scalpel, because although the blade cuts, the excimer laser was seen to remove tissue. It created a curve, that is, it does not incise the tissue but ablated the tissue, and the tissue got expelled from the surface of cornea. So with this thought in mind and this quest for an ideal treatment, there was development of advanced surface ablation techniques and LASIK, with PRK predating LASIK, but further focus on surface ablation caused the development of procedures like laser-assisted subepithelial keratectomy, also called as LASEK, and epithelial LASIK or Epi-LASIK or Epipolis LASIK. This is a representative video of excimer laser PRK, which treats emetropia using a 193 nanometer argon fluoride excimer laser and reshapes the anterior corneal stroma by photoablating after removing the epithelium. Now, the process of excimer laser photoablation at the corneal surface is very predictable, it's very accurate, and it's very reproducible. However, problem is that the final outcome is always influenced by the wound healing response of the body of the patient, because the central Bowman layer and the anterior stroma are ablated. And then there is a problem with the epithelium, which grows over the epidefect which has been created. And this epithelium remodels over the surface of the cornea in healing. Now, in several circumstances, surface ablation may be a better option than flap or lenticule-based procedures. For example, if there is a treatment of a patient who is prone to a traumatic flap dislocation, for example, somebody who works in the army or with athletes who play contact sports, we would prefer to do a surface ablation for such a patient. Or when there is a patient with, say, relatively large pupils, because these patients may experience symptoms of glare and halos in the event of the flap decentering, if we are doing a flap-based procedure, or, for example, an abrupt border of their wider than the flap diameter being ablated. Again, at the same time, there may be patients who may be at a risk for developing keratectasia, like, for example, patients who have got thinner or irregular corneas. They would be better suited for surface ablative procedures. At the same time, patients who would have very deep set eyes, small palpebral fissures, or very prominent orbital roofs, those would be the patients we would consider more for surface ablation. Now, some patients may not be eligible for flap or lenticule-based procedures because of the kind of corneal surface irregularities which they have, because those irregularities may predispose them to irregular thin or buttonholed flaps, and these patients are better not treated with flap-based procedures like LASIK. For example, patients who have hemimeridional asymmetry or very high or very low keratometry readings or a low Paki. So treatment on the corneal surface rather than under the flap would be preferable in these patients. Also, it would be preferable in patients, say, for example, if someone has a chronic blepharitis, and we know that in the longer run, patient might require lid massages. So we would avoid a flap-based procedure. Now, in patients who have had recurrent corneal erosion, surface ablation techniques would not only correct the refractive error, but might also ameliorate the recurrent erosions. again, in the rare event of any intraoperative or postoperative infection, at least theoretically, it would be easier to manage an infection in a post-surface ablation, in which case the infection would probably start at the epithelial level rather than when the infection happens in a flap or lenticule-based procedure post-surgery at the intrastromal level and is covered by epithelium, so is more difficult to treat. Also, the ability to modify initial refractive corrections plays a very important role when evaluating a treatment modality in general. I'm so sorry for that. Am I still audible?
Yes, we can hear you, ma'am.
Yeah, just a second. Yeah, so I was talking about the ability to modify initial refractive corrections, which plays an important role when evaluating a treatment modality in general or for a particular patient. Retreatments with surface ablation procedures have been performed after prior surface ablation or on top of a flap-based or lenticule-based procedure and after IOL implantation. So surface ablation is basically a preferred treatment when we have already done some procedure for the patient. Say we have done a flap based or a lenticule based procedure, and if we want to do a recorrection or an IOL implantation has happened, and then we want to recorrect the patient for any errors. Now, whenever we are seeing the patient pre-operatively and we want to examine the patient, a full ocular examination is mandatory. An external examination should consider the orbital anatomy. A deep-set globe, a high brow, or a narrow palpebral fissure may favor PRK and LASEK over LASIK, Epi-LASIK or Epi-LASIK. Because with LASIK, Epi-LASIK or Epi-LASIK, it may be difficult or impossible to access the microkeratome and apply the suction ring or the patient interface. Now, we also have to examine the extraocular movements. It is important because the presence of any phoria or atropia could result in post-op diplopia. Pupil size should again be measured because a large pupil may contribute to glare and halos post-operatively. Although improved understanding of dim light vision symptoms has also suggested that it may just be the corneal aberrations and not the pupil size itself. But a commercial pupillometer can accurately assess pupil size under both mesopic or scotopic conditions. And we nowadays have a lot of instruments that can help us to assess the preoperative aberrations, total aberrations of the eye as well. Again, eyelids and tear film have to be evaluated for blepharitis or dry eye. That should be treated preoperatively. So in case some patient has any dry eye related issues, you always treat them preoperatively rather than postoperatively. Okay. Again, examination of the cornea is very important. This is the cornerstone of doing any ablative treatment, maybe surface ablation or a flap based procedure or a lenticule based procedure. And there has to be emphasis on preoperative ruling out of corneal scars, vessels, or previous inflammation. There are patients who have got epithelial basement membrane disease, which is also called as map dot fingerprint dystrophy. They are better candidates for excimer laser surface ablation, which in this case may be therapeutic because it allows enhancement of epithelial adhesion. Now, preoperative corneal pachymetry is mandatory for all patients. Central corneal thickness is determined by a Scheimpflug or scanning slit topographer. Corneal pachy can be a screening test for pre-existing ectasia or keratoconus, and it can determine the amount of corneal tissue which is available for excimer tissue ablation without a risk of weakening the cornea, where postoperative ectasia or irregular astigmatism can become significant risks. Next, we come to tomography. Tomography is vital in the preoperative evaluation of all refractive surgery patients. Corneal topography and tomography are useful in evaluation of irregular astigmatism, ruling out corneal warpage, which can occur with the use of contact lenses, and also to decide on the kind of procedure which we want to do for the patient. Now, you also have to always examine the lens to rule out an early cataract. We have to do a dilated fundus examination to rule out pre-existing peripheral retinal degenerations or peripheral holes that have to be treated pre-operatively. Eye dominance is tested if the patient desires monovision. For example, if we are planning the patient for a monovision correction, then eye dominance is very important because the dominant eye is typically corrected for distance vision. Now, soft contact should not be worn for a minimum of 3 days, and hard contact should be avoided for at least 14 days prior to the preoperative evaluation. Now, if corneal warpage is being suspected, the patient should not wear any contact lenses until the topography is stabilized. Careful evaluation of patient's refractive status is very critical. This is the most critical step in evaluating a patient for surface ablation. Now, refraction should be stable to within a 0.5 plus minus 0.5 diopter over the previous year. And visual acuity should be checked without correction, as in the uncorrected visual acuity, as well as the patient's current spectacles. That is, whatever is the current spectacle corrected visual acuity. Manifest refraction and cycloplegic refraction have to be done. Corneal topography is useful in also evaluating astigmatism. So we have some cross-reference with the subjective astigmatism. If there is a clinically significant disparity between the manifest and cycloplegic refractions, then patient needs to be evaluated further. Most patients will have cycloplegic refractions up to 1 diopter in the area of hyperopic shift post dilatation. That is because once we dilate the patient, the optics of the peripheral cornea also come into play, and a small posterior shift of the crystalline lens happens when we dilate post cycloplegia. So laser input may be planned based on the manifest refraction if it has been done after carefully defogging the patient. A disparity between the manifest and cycloplegic refraction of more than 1 diopter of sphere gives us an indication that the patient needs to be re-evaluated. So in this, we usually include a post-cycloplegic manifest refraction plus addition, or we also call this pushing plus, to overcome accommodative spasm. Now, usually when myopes come to us, I'm sure most of us would have seen in OPDs, they're usually overcorrected, but they are over minused in their contact lenses or spectacles, because the extra minus, although it causes a minification of the overall image that the myope is able to see, it also causes a perception of higher contrast or improved sharpness of the visualized image. And in hyperopes, those who have a habitual accommodation to improve distance vision. So this is a very important test, this pushing plus, to overcome that accommodative spasm before you decide what is the final correction of the patient. Because it is only that correction that you are actually going to feed in the machine, and the machine is going to correct for you. So a cycloplegic refraction is mandatory in all patients, especially in middle-aged patients, because there may be a lot of accommodative spasm in these patients. Right, now, if a discrepancy exists between the patient's refractive and corneal cylinders, what do? We should re-evaluate the refraction. At the end of the day, basically, proper patient education is the key to a successful refractive surgery procedure. The goal of the surgery is to decrease the patient's dependence on both glasses and contact lenses. And achieving this goal depends on what are the patient's daily visual needs. The patient must understand that this technique is still not as accurate or as predictable as correcting myopia with, say, contact lenses or glasses, because it is a machine-based procedure. So ensuring that the patients understand the goal of the procedure will increase post-operative satisfaction. Informed consent should always include a discussion of surgical and non-surgical options, likely outcomes, the potential need for enhancements, and whatever potential foreseeable complications are there. Again, if we are going to correct a patient, we have to explain presbyopia to them, because most of the myopic patients who come to us, and even the hyperopic patients who come asking for a hyperopic correction, they are under the impression that this will take care of all the glass prescriptions for all lifetime to come. They have to be explained that presbyopia comes at around 40 years of age, once we go into the middle ages. And if we are offering an option of monovision in a hyperopic correction to a patient, we have to, or in a presbyopic patient in which one eye is intentionally left mildly myopic for near vision, in these cases, patient has to be explained what it means, and not just explained, something called as a monovision simulation should be done with contact lens prior to the procedure. So the patient should exactly know what they are entering in for. Now, when considering refractive surgery, several issues have to be evaluated preoperatively. Now, this table basically shows the broad ocular and systemic contraindications against surface ablation procedures. Now, evaluation of pre-existing ocular or systemic conditions that could possibly interfere with healing or the predictability of the procedure, evaluation of the patient's refractive status, including stability, degree of error, astigmatism, and last but not the least, evaluation of patient's goals and expectations from the surgery. We have to obtain the patient's full medical history. We have to review all the systems. We have to perform a complete ocular examination to rule out the presence of any conditions in which the refractive surgeries might be contraindicated. A history of collagen vascular and autoimmune diseases like rheumatoid arthritis, SLE, Sjogren syndrome, these are considered contraindications to surface ablation because there is an unpredictable corneal wound healing and there is a potential for corneal melting when these conditions are present. A history of keloid scar formation and prior herpes simplex keratitis are all relative contraindications. Systemic antiviral prophylaxis, when started preoperatively and continued for several months postoperatively, may make surface ablation safe in patients with prior herpes simplex keratitis. However, I know of a lot of surgeons who would not like to operate if the patient has any indication that there has been a previous attack of herpes simplex keratitis, or there is a healed scar which shows signs of being a viral scar. Now, diabetes should be well controlled preoperatively because it involves instability of refraction and potentially poor wound healing. And dense amblyopia is a relative contraindication because the refractive procedure puts the patient's better eye at risk. Now, once we advise a patient for surface ablation on the day of the surgery, the following steps may be undertaken. The first step that we do is the calibration of the laser machine. So the day of surgery, laser has to be checked for an adequate homogeneous beam profile, alignment, and power output following the manufacturer's guidelines. Now, when we go to the preoperative planning, many surgeons employ a nomogram adjustment to the correction to be programmed into the laser. It is basically preferable to do these calculations before surgery, well before surgery, to avoid the time pressure or distractions that may lead to calculation errors at the last moment. Most nomograms are usually individualized to the surgeon, to the laser, the specific technique being used, also amount of correction, patient age, gender, and other variables. These factors all will influence the outcome of the ablation. Now, often the manifest and cycloplegic refractions differ, like we spoke. The amount of access on topographic and refractive astigmatism differ. Consequently, it may be unclear which refraction has to be entered. Now, if the refractive cylinder differs from topographic cylinder, it is assumed that lenticular astigmatism or posterior corneal curvature is the cause. In this case, laser is usually programmed with the axis and amount of cylinder noted on manifest refraction. Now, the consistency of the axis on the refraction and topography should be checked with the value programmed into the laser. This is a common source of error, especially when there is a conversion between plus and minus cylinder formats. In many lasers, the size of optic zone has to be entered and a determination has to be made whether or not a blend of the ablation zone has to be performed. So mostly nowadays we do ablation taking into account a blend zone or a transition zone, which is an area of peripheral asphericity that is designed to reduce the possibly undesirable effect of an abrupt transition from an optical zone to an untreated cornea. For example, say if a patient is being treated of a -6 diopter correction, we may do a -5 diopter correction at a 6 mm optical zone, and then for the rest of the 1 diopter correction, we may take an 8 mm overall, 2 mm around the 6 mm, right? And larger the treatment area, deeper is the ablation. In simple spherical corrections of myopia, the approximate depth of ablation is calculated by Munnerlin's formula. If I'm not wrong, I think this has already been discussed in a previous class. Munnerlin's formula gives us the approximate depth of ablation, as in the formula says T is H square into D divided by 3, where T is the thickness of the tissue ablated in microns, H is the diameter of the optical zone in millimeters, and D is the dioptric correction. So you can, in your mind, get a rough idea about how much tissue we are going to be ablating. Now, when we prep the patient before the laser treatment is performed, patient has to be instructed about the sound and smell of the laser and the feel of the operating room. If needed, if we feel, patient may receive an oral sedative, and the operating eye in unilateral treatments, if they are being done, should be indicated with an adhesive label or some other temporary mark on the forehead. The patient's skin is prepped with betadine or alcohol wipes. A sterile drape is used over the skin and the lashes. Lashes are kept away from the treatment area. Topical tetracaine or proparacaine anesthetic drops are placed in the eye. A lid speculum is placed in the operated eye, and we may choose to put a patch over the fellow eye to avoid cross fixation. A gauze pad may be taped over the temple between the operating eye and the ear to absorb the excess fluid runoff. The amount of desired correction accounting for the vertex distance is entered into the laser and checked by the surgeon. The patient is then asked to fixate on the laser centration light while the surgeon focuses and centers the laser. Now, for most of the patients, line of sight fixation by the patient during surface ablative procedures like PRK produces more accurate centration than surgeon trying to immobilize the globe. So we have to counsel the patient well pre-operatively and let them take a lead for fixation during the procedure. Now, once the treatment is, epithelium is out of the treatment zone and the treatment is started and the stroma has been exposed with one of the techniques, laser is centered and focused according to the manufacturer's recommendations. Improved centration in surface ablation happens when aiming beams or reticule is centered on the entrance pupil. If you can see the picture on the right, instead of the corneal apical light reflex. So the patient is instructed to maintain good fixation during the stromal ablation. Now, normally what happens if although the duration of the laser is usually not very long, but small microsaccades can happen, but they have not been shown to adversely affect the outcome of the procedure. Now, if you feel at the time of surgery, patient is he's beginning to lose fixation, we can just pause the treatment, talk to the patient, achieve refixation, and then resume firing the laser. Now, these problems are kind of circumvented if the laser includes a tracking mechanism, but it is still important for the surgeon to monitor for excessive eye roll, which may still result in decentration despite the tracking device. Now, if you look at the picture on the schematic diagram on the left side, to correct myopia, the surgeon flattens the cornea by placing the maximum number of laser pulses centrally and progressively fewer pulses towards the side or the periphery. To correct hyperopia, the cornea has to be steepened, so no pulses are given in the center. The maximum number of pulses is placed in peripheral optical zone, over here and over here. And then a blend zone creates a smooth transition from the edge of the optical zone back onto the peripheral corneal surface. Now, there are various surgical techniques which are employed under the general umbrella term of surface ablation: photorefractive keratectomy, laser subepithelial keratomyeliosis, Epi-LASIK, also known as epipolis LASIK, Epi-LASIK, also called as E-LASIK, transepithelial photorefractive keratectomy, and the lesser known Epi-Baumann keratectomy and sub-Baumann keratomyeliosis. Now, talking about photorefractive keratectomy, the general technique in PRK or photorefractive keratectomy starts with anesthetic eye drops being applied and epithelium being removed using either a mechanical scraper or a specialized brush called as Amoli's brush, or by using alcohol or by using the laser itself. An excimer laser controlled by the computer is then programmed to reshape the cornea depending upon the amount and type of correction desired. The laser sculpts an area 6 mm to 9 mm in diameter on the surface of the eye, depending upon whether we are correcting for myopia or hyperopia. Depth of the sculpting depends upon the degree of correction needed. Laser removes tissue from the cornea, either decreasing the steepness of curvature for myopia or increasing the central steepness for hyperopia. Now, this is a short video showing the technique of surface ablation using excimer laser, specifically PRK. These are exactly the steps that I have just described. Just want to say again here that there are three techniques of epi removal in PRK. One is what is being shown here, the alcohol-assisted epithelial removal. In this, 18 to 20% ethanol is placed inside a 7 to 9.5 mm central corneal well for around 20 to 40 seconds. The alcohol is then absorbed with a dry PVA sponge and residual alcohol is washed away using copious irrigation with BSS, and then the laser is used to ablate the cornea, and then a PCL is placed. The second method to remove the epithelium would be mechanically, by either manually scraping using a blade or using a rotating brush like Amoli's brush, and then moistened by a damp PVA sponge. And the third mechanism is to remove the epithelium using laser itself. Now, there are various conditions when doing a PRK would be more favorable to overall outcome. For example, it is like we have already talked about this, recommended for patients with lower levels of myopia or hyperopia, recommended for those with thin corneas, patients who have dry eyes, and because a stromal flap is not created in the cornea, less corneal tissue is disturbed. Therefore, some surgeons consider PRK to be a safer procedure than LASIK. And there may be a certain occupational restrictions. We have already spoken against other forms of refractive surgery like flap-based procedures like LASIK. Also, PRK is a less invasive procedure than intraocular surgery, and therefore reduces quality of vision complaints postoperatively. Now, there are some considerations against PRK. PRK, as we all know, it provides slower visual recovery than either LASIK or phakic IOL. It is not recommended for people who have got significant ocular diseases of any type, or any significant systemic or skin diseases, or those who have a history of keloid formation or excessive scarring, or those who have unstable or changing refractive error. And patients who have very low pain tolerance, they are not good for this surgery, because there is some pain immediately following the surgery, which may last for up to 2 to 3 days. And occasionally this kind of pain may require narcotics or topical anesthetics for pain control, and therefore we have to choose our patients very carefully. Now, coming to LASEK, what is LASEK? LASEK is laser epithelial keratomyeliosis. It is a surface ablation procedure for correction of refractive error, which combines elements of LASIK with PRK. Now, in LASIK, dilute alcohol is used to loosen the epithelial adhesion to the corneal stroma. And then the loosened epithelium is moved from the treatment zone as a hinged sheet. Then laser ablation of the subepithelial stroma is done, and epithelial sheet is returned to its original position, like we do with the LASIK flap. Now, goal of this procedure is to avoid the flap-related LASIK complications and the biomechanical complications of LASIK-induced ectasia. Also, to reduce stromal haze after PRK. So I'll explain in one of the upcoming slides how that happens. In the LASIK variant of PRK, which was first described by Camelin, goal is to preserve the patient's epithelium. So instead of debriding or discarding the epithelium or ablating the epithelium with excimer laser, the surgeon removes an intact sheet of epithelium. These are the steps undertaken with the LASEK surgery. gentian violet marks in the shapes of rings or straight lines are often made after marking the area to be ablated. A solution of approximately 20% diluted absolute alcohol is applied for 20 to 30 seconds in a well. The alcohol is restricted to the area to be de-epithelialized. Usually the well is an optical zone marker or a ring which is pressed onto the corneal surface, or may also be done by means of a round surgical sponge which is soaked with alcohol solution. After the desired exposure time has elapsed, alcohol is removed by absorption onto a microsurgical spear sponge, and then optical zone marker is removed. The ocular surface is copiously irrigated with balanced salt solution to minimize toxicity to the limbal germinative epithelium. An instrument which often has a spatula-like configuration is used to separate a flap of full thickness epithelium from the underlying Bowman's layer. Epithelium is delicately folded back on itself until all the epithelium has been removed except for a small hinge, which is usually located superiorly. The rest of the steps are same as for surface ablation. Excimer laser controlled by a computer is programmed to reshape the cornea. Laser removes the tissue from the stroma, reshaping it corrects the refractive error, and the epithelium is then smoothened back over the stroma, and a BCL is placed over the cornea to promote healing. The goal of LASIK is to reduce post-operative pain and achieve a speedier return of vision compared to PRK, and possibly reduce the post-operative haze formation. Now, what are the various considerations for LASIK surgery? Now, LASIK may be recommended for people who have lower levels of myopia or hyperopia, for patients, people with dry eyes, and because a stromal flap is not created in the cornea, less corneal tissue is disturbed. Therefore, some surgeons again consider this procedure to be better than LASIK. And there can be certain occupational restrictions in flap-based procedures like LASIK, which might not apply so much to the LASIK group. LASIK is less painful during healing than PRK and may offer a faster visual recovery, but not as fast as LASIK, of course. And this is a less invasive procedure than an intraocular surgery. Now, what are the considerations against this surgery? Again, same considerations as we have talked about in PRK, same are the considerations against LASIK surgery as well. The only one plus point that goes in favor of LASIK is that there may be some discomfort immediately following surgery, lasting for about a day or two. But it is not the patients who undergo these surgeries, they usually do not complain so much as compared to the PRK patients, right? So then there is a surgery, this is called an Epi-LASIK. A variant of LASIK is also called as Epipolis LASIK. It's called as Epipolis LASIK because there is a use of an epitome in this surgery. It is actually evolved from LASIK. So the aim was to separate the epithelial flap without the use of alcohol, because like I explained just now, so whenever we use alcohol in a well, we are supposed to copiously wash the surface with BSS or sterile normal saline, so that there is no after effect of or toxicity of the alcohol on the limbal epithelium. So to avoid that particular thing, this Epi-LASIK surgery has evolved from LASEK. In this procedure, and there is a special blade which is used, it's called an epitome. It is a blunt oscillating blade. It is used to remove the epithelium before excimer laser treatment. The epithelial flaps are created without preceding use of any alcohol solution, and it was Palikaris who introduced epipolis laser in situ keratomyeliosis in 2003. Many surgeons use Epi-LASIK for definitive epithelial removal, and they do not reposition the epithelial flap after excimer laser ablation. So then this turns into essentially a variant of PRK. Now, efforts have been ongoing to develop a variant of the microkeratome used in LASIK for Epi-LASIK. The microkeratome is modified with a dull blade and a thin applanation plate to mechanically remove the epithelial flap without the use of alcohol, as is used in LASIK. The goal of this is to create a viable epithelial flap, which hopefully may successfully re-adhere post-operatively. And all of these techniques are now grouped together as Epi-LASIK. Now, for this kind of a procedure, we have to be careful about any past ocular trauma that the patient has had, especially corneal abrasions or foreign bodies. And we also need to ask if patient has undergone any previous ocular surgery or corneal surgery specifically. Any history on part of the patient which suggests that they could have undergone any procedure on the cornea could affect our decision to perform an Epi-LASIK, because the translation of the mechanical device depends on having an intact Bowman's membrane. A scar or previous disruption of the Bowman's layer could cause a stromal incursion of the blade. That is, the blade could cut through the Bowman's layer and go directly into the stroma. This is a complication actually very unique to Epi-LASIK. This may cause a stromal defect, which results in an irregular astigmatism with an impaired visual acuity post excimer laser ablation. So ensuring a flawless blade before epithelial flap preparation and ensuring that the patient has had no corneal surgery previously or no injuries previously is therefore important to avoid this potentially severe complication. Now, there are various advantages of this procedure. It eliminates, obviously, the alcohol application from the procedure, causes a faster healing rate, less pain for the patient. It produces precise, reproducible separation of the epithelium. With Epi-LASIK, many of the flap complications are reduced. It results in less post-operative haze. The epithelial flap basically protects the bare surface of the stroma after laser and prevents the influx of the inflammatory mediators which come from tears. Because the corneal nerves are not severed, there is a lower risk of extended post-op dryness. Again, it is a better option than LASIK for those who have got thin corneas. With this procedure, approximately, it has been said that 35% less tissue is removed. That means that many patients who have thinner corneas would be great candidates for a laser vision correction using Epi-LASIK. And Epi-LASIK also provides a more predictable outcome for customized laser vision corrections. Now, we have to understand what is really the difference when we talk about LASIK versus Epi-LASIK. Under the surface, there are subtle anatomical differences between the two procedures. When we do an alcohol delamination in LASIK, it breaks the hemidesmosomes that join lamina lucida with lamina densa. Okay, so these two layers are together, but when we apply alcohol, the hemidesmosomes break and these two layers separate. So the Epi-LASIK cut separates the whole of the basal membrane from the Bowman's layer. The subtle layer of lamina densa that covers the Bowman's layer determines the superior quality of the stromal surface that is obtained in LASIK, because lamina densa is smoother than the Bowman's layer. However, when we talk of Epi-LASIK, it was developed to avoid the cellular damage which was produced by the epithelium or by the alcohol on the epithelium, and enhance the quality and viability of epithelial flaps. But when these two procedures were compared, researchers found that there was a weak point of Epi-LASIK, which was a high risk of damage at the hinge level. So as the epikeratome reaches the other side, it tends to tear the epithelium, and there was just too much incidence of free caps, which basically turned these Epi-LASIK cases into PRK. In addition, they compared post-operative results of LASEK and Epi-LASIK patients, and they found that use of alcohol had little or no influence on the overall results. Right? What is important basically in these procedures is it's been found that it's important to have an epithelial flap. It may not be so important to have a viable epithelial flap, a beautifully preserved epithelial flap, which we are hoping would re-adhere successfully, because the flap would anyway be slowly replaced by new epithelium after the procedure. Now, there is this procedure called Epi-LASIK. Now, Epi-LASIK is similar to Epi-LASIK, except that instead of the epitome alone, alcohol is also applied for 20 seconds before making the flap. Similar to that in the Epi-LASIK treatment group. Okay, so you apply alcohol that is used to help in epithelial loosening. Then you use the epitome. It is used to perform epithelial separation. And then rest of the steps are the same. Now, this procedure has also been called as epithelial LASIK or E-LASIK. This technique was developed primarily for patients who had thin corneas or irregularly shaped corneas. So while in LASIK, alcohol is used to loosen the epithelium and it is swiped aside with a blunt instrument with manual scraper. In Epi-LASIK, both alcohol and epikeratomes are being used. Okay, this procedure was mentioned first by Camillin et al. And they used it because they theoretically said that it could combine positives of both LASIK and Epi-LASIK. Aim being to separate the lamina lucida from the lamina densa. Theoretically, if we look at it, it is the best, easiest, and smoothest separation of the epithelium possible. And it also obviously overcomes the hinge-related problems which are faced in epipolis LASIK. However, there have been a lot of prospective studies which compared Epi-LASIK with Epi-LASIK and found that Epi-LASIK treatment group had less post-operative astigmatism and irregularities than the Epi-LASIK group. Addition of alcohol in the Epi-LASIK treatment group contributed to better flap and hinge creation, and also there was no increase in pain or post-operative haze in the Epi-LASIK treatment group. Now we're coming here to trans-PRK. Now excimer laser itself may be used to remove the epithelium in trans-epithelial photorefractive keratectomy. In this variant, epithelium itself is removed by the excimer laser by monitoring the disappearance of blue fluorescence during the ablation. The cornea undergoes an epithelial ablation first within a fixed diameter. OR room lights are turned off, blue fluorescent light is emitted, epithelium is ablated. Once the blue fluorescence disappears, this indicates epithelium has been removed. Laser system is then reprogrammed with the appropriate refractive error correction for a corneal stromal ablation. Right. Now, the use of epithelial fluorescence as an endpoint for initial PTK is subjective. And there is always a fear of over-treating and thus losing precious stromal tissue or under-treating in such patients, right? Now, I want to give a quick word here about the Schwind-Amaris excimer laser system. I have no financial disclosures. It is used for one-step transepithelial photorefractive keratectomy, which is a true trans-PRK. It is a touch-free laser eye correction procedure. The procedure relies on proprietary software, which is available on the Amaris excimer laser platform. It's called the ORK CAM software. The excimer laser fires the PRK treatment profile first, that is, it ablates the stroma first, and then switches to a defined depth radial PTK mode. So the entire laser treatment is performed in one step, instead of the procedure being split into PRK and PTK modes as we usually do. Now, quick word on two more less heard of procedures. One is sub-Bowman keratomyeliosis, also known as thin flap LASIK. During SBK, a microkeratome is used to create a corneal flap that is 90 to 110 micron thick. An excimer laser is then used to perform corneal ablation. Major advantage of creating such a thin flap is leaving sufficient stromal tissue to allow for safer excimer laser ablation, especially in patients who have got moderate or high myopia. There are some advantages of SBK over traditional LASIK. It has a faster recovery, reduced risk of dry eye, superior visual outcomes. It preserves corneal tissue more and has a lower risk of complications. Epi-Bowman keratectomy is a novel variant of PRK. Instead of a metallic blade, a different instrument is used to remove the epithelium. This is a new dynamic multi-blade single-use device. It's called Epiclear. It is a handheld device with a bowl-shaped single-use flexible head consisting of biocompatible polymer. The tip has a central groove with double-bladed rims. It is designed to remove the epithelium layer by layer as it is repeatedly swept across the corneal surface with gentle pressure. So if you look at this schematic, the motion of the instrument is utilized to remove the epithelium by sweeping it across the corneal surface, just like that. And the removed epithelial cells are then discarded. Once the adequate exposure is obtained, then the excimer laser is fired and refractive correction is obtained. Now, while other mechanical instruments may damage Bowman's layer during epithelial removal, the comparatively softer material of the EpiClear device may a small video. This is from a research article where scientists compared epi-Bowman keratectomy with alcohol-assisted PRK with respect to wound healing and complications, showing how the instrument works in a human cornea real time. So if you look at the pictures here, pictures A to F show illustration of epithelial removal. This is an untreated cornea. Then from B to E, you'll see epithelial removal happening by sweeping movements until the Bowman's layer is reached. And then this F picture shows complete epithelial debridement. Now, some authors have reported that EpiClear PRK yields superior results compared to alcohol-assisted PRK in terms of like higher patient comfort, faster healing, and faster visual recovery. But in Epi-Clear PRK, inferior results have been obtained as compared to alcohol-assisted PRK when wound healing and complications were compared among two groups, comparable groups, right? So this is a table showing comparison of ranges of correction, functional visual recovery, complications, and relative contraindications between various surface ablation procedures and flap-based procedures like LASEK. As we can all see, all specific complications seen in flap-based procedures like free caps, epithelial ingrowth, corneal ectasia, and DLK will all be avoided with surface ablation. And surface ablation is more amenable in general to corneas which are thinner and patients who have dry eyes. Now, what are the risks and possible side effects of advanced surface ablation? Overcorrection or undercorrection with a possible need for retreatment, blurry vision for a few days up to several weeks with achievement of best vision taking up to a month or longer, glare and halos around lights, particularly at night, corneal scarring, corneal haze, and corneal. But there are considerations with regards to the cilial corneal haze, which typically appears several weeks after surface ablation, peaks in intensity at around 1 to 2 months and gradually disappears during the next 6 to 12 months. Histologic specimens obtained from patients who have undergone surface ablation reveal a continuous acellular collagen layer underlying the epithelium. And human studies have indicated that this haze is primarily composed of glycosaminoglycans. Subepithelial stromal tissue reformation following PRK or photorefractive ablation is attributable to abnormal activation or proliferation of keratinocytes. Now, in refractive surgery, patients with high myopia are at risk of haze formation. Early haze has been seen only attempted small male gender more than 80 microns, and if the patient somehow discontinues topical corticosteroids early on postoperatively. Haze has also been found to respond to an increase in frequency and intensity of steroids. If clinically unacceptable haze persists, treatment with topical mitomycin C alone, a superficial keratectomy, or a PTK with or without MMC may be performed as treatment. But we have to always remember that any re-ablations that we want to do have to be delayed for at least 6 months, because the refractions when the haze is coming in are often inaccurate, because the haze makes us overestimate the amount of myopia that we are looking at in the patient. And also there have been a lot of measures that have given to decrease haze, for example, intraoperative mitomycin C, that's the most commonly used one. We'll be speaking about that in just a second. Patients undergoing vitamin C was shown to be associated with decreased prevalence of corneal haze. Use of chilled or cold balanced salt solution to reduce corneal haze has also been advocated by a lot of people. Now, next is the use of mitomycin C. You all know mitomycin C is an alkylate antibiotic substance with anti-proliferative and anti-fibrotic actions. It used as an adjunctive agent of
Can you also
and regression of correction.
Or is it just
Topical MMC 0.02% applied for 2 minutes on the exposed stromal bed has been successfully used to treat subepithelial fibrosis after RK or SA. The corneal surface and the entire conjunctiva are then vigorously irrigated with 20 ml of cold normal saline or solution to remove residual vitamins C. And in patients who have a higher fracture, so MMC is a uh, trendy. Now, coming down to epithelial remodeling, visual rehab after surface ablation and subsequent haze formation all depend upon reepithelialization. Healing of the cornea is initiated by release of inflammatory cytokines, for example, TNF-alpha, and the sorry for that. I think I got there again.
Dr. Amita, it could be because of the bad weather that your network connection is unstable. You can just switch off your video for some so that your audio is more clearly visible. Or sorry, we can hear you better if you will just switch off your video for some time. Maybe that will help with the network traffic.
Am I audible, Kanika?
Yes, you're audible, ma'am. There are some glitches in between. Previously, for the few minutes, we are not able to hear clearly.
Okay. All right. No, we were on epithelial remodeling. Now, visual rehab after surface ablation and subsequent haze formation depend upon reepithelialization. We said that healing of the cornea is initiated by release of inflammatory cytokines like interleukin 1, TNF alpha, and fast ligand by the damaged corneal epithelium. And this leads to apoptosis of underlying keratocytes at the damaged epithelium and also some distance into the stroma. Also, there is a reflex lacrimal gland secretion, which increases both tear production and concentration of various growth factors, which initiate and assist both epithelial and stromal healing responses. Now, the wound healing response is basically very complex and subject to inter-individual variation, and it can cause both delayed and excessive epithelial or stromal healing processes. We don't know what drives a particular excessive healing response in a patient, but surface ablation techniques which retain at least a partially intact epithelial basement membrane theoretically have been said to improve or regularize healing. And studies have also shown efficacy in reducing the levels of TGF beta through the use of epithelial flap techniques when compared with epi-off surface ablation like PRK. However, then there are factors like retention of dead epithelial cells within the epithelial sheet, which we are replacing. These raise the potential to paradoxically increase the healing time or prolong the healing response. Whereas removal of the epithelial flap might allow relatively quick reconstruction of the epithelial stromal interface and regeneration of new basement membrane. And hence the use of Epi-LASIK, which was aimed at preservation of the healthy epithelial flap, has caught everyone's attention. Now, when we talk about post-op care, immediate post-op treatment, once a procedure is completed, antibiotics, steroids, and sometimes NSAID drops are placed in the eye, and then a bandaged soft contact lens is placed. Chilled balanced salt solution may be applied after the PRK procedure with the aim to cool the cornea down and thereby reduce pain and haze formation via the activation of TRPM8 channels. If the patient cannot tolerate a bandage soft contact lens, a pressure patch may be used. The topical NSAID drops have been shown to significantly reduce post-op pain, but they have a downside of slowing down the rate of reepithelialization and promoting sterile infiltrates. A reduction in pain with use of topical anesthetic drops has been demonstrated, but they have to be used very cautiously because they are fraught with corneal complications when used excessively and over a prolonged period, turning their use controversial. A bandage contact lens protects the deepithelialized cornea, decreases pain, results in faster reepithelialization. It is placed over the cornea until the epithelialization is complete, which is usually on postoperative day 3. Patients with BCL soaked in ketorolac 0.45% solution have been shown to have less pain immediately after the surgery than patients with a regular lens. However, this with type of BCL we are using, that may also cause problems with healing. For example, the use of a BCL can cause corneal hypoxia, especially with low oxygen transmissibility BCLs, those which have a low decay. Also, extended wear non-silicone hydrogel lenses may be associated with higher rates of infection. So whatever we use, we have to know the pros and cons of those BCLs. Right now, topical corticosteroids, they may range from fluorometholone 0.1% or prednisolone acetate. They may be used for some weeks following surgery to modify the inflammatory response. Usually, they are used from a few weeks to a couple months. The healing epithelial defect and the BCL may both lead to sterile infiltrates, and these sterile infiltrates are also well taken care of by using topical corticosteroids. Now, topical antibiotics like fourth generation quinolones, they provide a broad spectrum activity against both gram-positive and negative organisms. There is an increased risk of infection with the use of a BCL over a healing epithelial defect, so antibiotic cover is mandatory with BCL use. Surface ablation damages lesser corneal nerves than flap-based procedures like LASEK and induces less dry eye symptoms. However, there is a vast variation in dry eye symptoms due to decreased corneal sensitivity and blink rate, which can both happen after surface ablation. So additional mechanisms that can worsen dry eye include toxic conjunctivitis, medicamentosa from too many drops being used, or a flattened corneal surface with altered tear flow dynamics. So it is always advisable to use preservative-free tear substitutes for an extended period, especially with patients who use screen for their work. Now, post-operative care during the first 24 hours, patient may experience pain, which has to be relieved. So we may give an oral narcotic pain medication, oral analgesics, including NSAIDs, gabapentin or pregabalin, if it so warrants, looking at the patient's reaction towards the pain. And patient has to be followed closely until the epithelium is intact. Steroid drops are usually tapered over a couple of months depending on patient's corneal haze and refractive outcome. Keratocyte healing activity is maximal at 1 to 2 months. Abrupt termination of drops around this time might trigger an excess healing reaction and cause haze formation. So we have to take care of that. Now, when we take of complications, one kind of complication that can happen with surface ablation is formation of central islands. Central island is usually disclosed by computerized VKG as an area of central corneal elevation, which is surrounded by an area of flattening corresponding to the myopic treatment zone in the paracentral region. Different studies have employed varying thresholds for saying or defining what a central island is. But generally speaking, at a minimum, an elevation of at least 1 diopter with a diameter of more than 1 mm compared to the paracentral flattened area should be present for us to define it as a central island. Now, islands usually occur with the use of wide beam laser systems, and with the coming up of scanning delivery systems, this complication has practically reduced a lot. Central topographic islands may be associated with decreased visual acuity, monocular diplopia and multiplopia, ghost images, and decreased contrast sensitivity. Now, there are a lot of theories about how the central islands happen. The plume theory is there. Then there is a lack of homogeneity of the laser beam theory, which is why the large beam lasers were earlier implicated. Differential corneal hydration theory states that for differential corneal hydration happens because of the uneven corneal surface hydration. And then there is a shock wave theory which says that as the laser strikes the cornea during ablation, the laser pressure wave may force water from the underlying stroma to the center of the cornea, and then this excess fluid acts like some masking agent, reduces the central ablation rate. And uh, then there is a final theory which implicates the wound healing properties of the cornea of the PRK. Basically, applying extra laser pulses, which come with the nomogram nowadays, usually calculated as a fixed percentage of the total number of treatment pulses to the central cornea, will reduce the incidence of central islands and broad beam lasers. And there are some things called as multi-zone and multi-pass techniques which have been proposed to result in a smoother ablation. If the island does not spontaneously resolve in a year, we may have to retreat directly with the excimer laser again, and treatment with topography guided excimer lasers and customized ablation algorithms has shown positive results. Now, optical aberrations including glare, ghost images, and halos after surface ablation have been reported. These symptoms are most prevalent after treatment with smaller ablation zones and higher attempted corrections. They are usually exacerbated at night, most prevalent in young myopic patients who have a large pupillary diameter due to an optical zone which may be smaller than the entrance pupil under conditions of dim illumination. A larger, more uniform, well-centered optical zone will generally provide a better quality of vision, especially at night. Decentration may again result in glare, halos, decreased visual acuity. More symptoms may be experienced if the decentration is more than 1 mm in severity, but may not necessarily show any symptoms if it is less than 0.5 mm. Patients who have larger pupils, they may experience symptoms with smaller amounts of decentration because induced aberration, principally coma, worsens in the periphery. Decentrations can be prevented through proper stabilization of the patient's head, and surgeon has to be alert to stop the ablation. We have spoken about it before. If the patient begins to lose fixation, just pause the treatment, get the patient's attention back up, and then you can redo the treatment, like start the treatment from wherever you have paused it. Pupil tracking technology has led to decreased amount of decentration and therefore improvements in overall outcomes. Eye tracking is more important for eyes which have a higher level of correction. Now, if the patient is symptomatic from a decentration, again, wavefront guided enhancement may reduce the aberrations induced by the decentration. It is also important to achieve accurate centration during the PRK procedure, therefore, to optimize a patient's visual potential. We've already spoken about haze. Subepithelial haze can come as a complication, and it usually responds to an increase in frequency and intensity of steroids. We have also already spoken about what are the measures to reduce haze: use of ultraviolet protective eyewear in the year following the surface ablation, systemic ascorbate administration, use of chilled balanced salt solution and chilled BCL in the procedure, and treatment of corneal haze post-surface ablation may be tried with topical MMC alone, with the superficial keratectomy, or a PTK with or without MMC. However, any re-ablation that has to be done has to be delayed for at least 6 months. Overcorrections again may be treated by inducing a myopic regression through wound healing by abruptly discontinuing steroids. If the overcorrection still persists, the wound healing response may be stimulated by epithelial scraping. Re-steepening of the cornea is accomplished by laying down of tissue through the stimulation of subepithelial haze. There is also some anecdotal experience-based evidence that wound healing response may be stimulated or epithelial regularity enhanced by placement of an extended wear contact lens for 1 or more months. If regression does not occur with this lens within 1 month, regression may be stimulated by having the patient to use a topical NSAID 4 times a day for 1 to 2 months and monitor the refractive status and perform serial corneal examination. However, this is all anecdotal and personalized surgeon-based treatment. There is no evidence in literature for this. Undercorrections may occur after PRK, most often when a significant myopic regression happens. The incidence and amount of myopic regression depend on the degree of correction that is attempted. Regression is markedly increased with optical zones less than 6 mm in dia. Individuals who experience regression after treatment of their first eye have an increased likelihood of regression in their second eye. So sometimes the regression may be reversed with aggressive use of topical corticosteroids. Alternatively, the patient can undergo a retreatment after the refraction is being deemed to be stable for at least 3 to 6 months. Now, we have to understand that retreatments are always less predictable than primary procedures, but they do reduce residual myopia that may be present after the initial procedure. Coming down to epithelial defects and infiltrates, epithelial defect which is created while doing the PRK procedure usually heals within 3 to 4 days with the aid of bandage soft contact lens. Frequent cause of delayed re-epithelialization may be dry eye or keratoconjunctivitis sicca, which can be obviously treated with increased lubrication, maybe with temporary punctal occlusion at times. Patients with undiagnosed underlying autoimmune connective tissue diseases or diabetes may have poor epithelial healing. So patient has to be closely monitored until re-epithelialization happens. In the early postoperative period, subepithelial infiltrates may happen. They are usually sterile and secondary to immune reaction. Rarely, infectious corneal infiltrates may happen that have to be treated with appropriate topical antibiotics after doing scraping and everything. Now, elevated IOP patients may experience an increase in intraocular pressure after PRK. Most cases of elevated pressure is secondary to prolonged therapy with the corticosteroids that are being given. Elevated pressures are usually controlled with topical intraocular pressure lowering medications and or reduce the corticosteroid to a lower strength and lower frequency and typically normalize once the steroids are decreased or discontinued. Now, unlike radial keratotomy, no significant change occurs in central endothelial cell density after PRK. This is something I haven't mentioned here. Just wanted to say one line about it. The polymegathism associated with contact lens use typically has been seen to improve after surface ablation procedures, as demonstrated by significant decrease in peripheral coefficient of variation of cell size, at least 2 years postoperatively. Now, early postoperative pain is the major limitation of PRK technique. The de-epithelialized cornea following PRK results in direct exposure of the nerve endings leading to pain. It usually takes, like I have said, 3 to 5 days for complete epithelialization of cornea to happen, and therefore use of a bandage contact lens in the meanwhile, and use of cold balanced salt solution to wash the eye. Topical NSAIDs, topical cycloplegics, anesthetics, oral analgesics have all been seen. These topical cycloplegics, which may reduce the pain over the first 2 to 3 days, but it has an effect on visual acuity. So you have to take them under advisement. Normally, BCL soaked in Acuvale or a cold BCL has been shown to provide better analgesia for a longer time than conventional methods of pain relief, especially after trans-PRK. Again, we just spoke about infection. It can be rare but potentially vision threatening. Risk for bacterial keratitis after surface ablation is 0.01 to 1% and is likely significantly higher than LASIK, secondary to the creation of the large epithelial defect and the use of a BCL which comes from outside. So common organisms are Staph aureus, coagulase negative, Staphylococcus and Streptococcus. Antibiotic prophylaxis should exert adequate cover, usually covering all gram positives and negatives. There have been a few reports in literature about fungal keratitis or mycobacterial keratitis happening after PRK and LASIK, implying that the size of the epithelial defect may not be the only factor. Viral keratitis has also been reported in literature after PRK. However, it was not clear whether it is secondary to the effect of the surgery or whether it is an unknown cause. So valacyclovir has been suggested for prophylaxis if there is a probable prior history of patient having herpes simplex keratitis. Ectasia is a rare condition in which the eye becomes progressively more myopic and gets irregular astigmatic topographic steepening, corneal thinning, and loss of uncorrected and corrected distance visual acuity. After refractive surgery, iatrogenic ectasia has been very well described in literature, and it is considered as one of the most severe and dreaded complications of this surgery. But when we go for a refractive surface ablation, the overall risk for ectasia has been shown to be substantially low than after LASIK. Occurrence of dry eye after surface ablation is again less. Now, there is something called a stromal incursion of the dull epitome blade. I have already spoken about this. This complication is unique to Epi-LASIK, may cause a stromal defect, causing irregular astigmatism and decreased visual acuity. And this can be avoided if we use a good blade before epithelial flap preparation. If the stroma is dissected as in LASIK, it is better repositioned and then allowed to heal. Glare and halos, again, may be caused by the formation of corneal haze or may occur when the pupillary diameter extends beyond the optical zone of excimer treatment. This usually happens in low light environments but can happen in patients with large photopic pupils pupils. Decentrations less than 1 mm are likely to be visually insignificant, but like I said, more than 1 mm, they can cause glare halos, diplopia, and decreased vision. Now, the effectiveness of PRK has improved markedly during the pre-market approved clinical trials which were conducted in the US from 1990 to 94. Broad beam laser systems were updated several times. Surgeons have now become more familiar with the technique. Size of the zone of the ablation zone has been increased. There has been improvement in beam quality, development of scanning slit and spot lasers. There have been new outcome analysis software programs. There is cyclotorsion tracking, implementation of wavefront guided and optimized treatments, and topography treatments. All of these have caused significant improvement in refractive surgery outcomes vis-a-vis surface ablation. And for increased accuracy and outcome stability, topography guided treatments and and wavefront guided treatments have been evaluated, and they are patients which have highly aberrated corneal topographies and a lot of irregular astigmatism, and we would not consider them for refractive surgeries earlier. Now with advanced surface ablation and topography guided treatments, we evaluate many more data points compared to just wavefront guided treatments and get a better results for these patients. Thank you so much for a patient hearing. It was a long class.
Thank you, Dr. Amita. I think that was the most
Kanika, I can't hear you. I think you have to unmute yourself.
Am I audible now? Yeah. Am I audible, Dr. Amita? Kritika, am I audible?
Yes, ma'am, you're audible, ma'am.
Still can't hear. Just a minute. Some issue with...
Hello?
Is it an issue with me?
I think so. I think your earphones must have been connected yet. Okay, so meanwhile, let Dr. Amita connect back. I would like to say this was a very extensive class, and definitely the residents and students who've attended this will be able to answer all the A to Z of surface ablation procedures. Like Dr. Amita has very elaborately explained the various procedures that come under this umbrella of surface ablation and what are their pros and cons and their indications and contraindications. So, I would also like to add a few words on surface ablation. Even though there have been concerns regarding the haze and the delayed post-operative recovery from surface ablation, but still, even in today's time, surface ablation procedures do make a major chunk of our refractive surgery procedures because, like Dr. Amit already informed, there are less chances of ectasia when we are comparing it to other techniques of refractive corrections. Yes, of course, the haze factor is there, and there are treatments like mitomycin C, which have been also added to all routine procedures in order to reduce the haze. Then there are various formula corrections, and there are various limits that have been decided beyond which the PRK should not be extended.
Should not be done. Correct, yeah.
There were reports of people correcting myopia of up to 12 diopters, minus 12 diopters using surface ablation techniques. But those practices have now been abandoned, and we have come to a very safe practice zone right now. Dr. Amita, I would like to ask, in your own practice, what is your safety margin or the safe limit beyond which you do not prefer to go for a surface ablation procedure, considering the risk of haze and corneal melts and infections?
So, like I said, I mentioned in the talk also, if I feel that my overall ablation is going beyond 80 microns, I would not like to do that. So, I'd like to restrict myself in post PTK, once the epithelium is removed, I would not like to go beyond 80 microns ablation, which, if you look at it more or less, comes to around 7.5 diopters of myopic correction. Yes.
And like you already mentioned in your class, it also depends on the area of ablation, the diameter of ablation.
Correct. Ablation zone. So a lot of things, basically the ablation zone is very important. So see, the thing is between us, and if you compare with the European population, their pupils are usually larger in size, right? So in them, the theoretically what the research that comes from West, it has to be taken with a pinch of salt in our population. So we can always keep a bit of a smaller ablation zone, right? That is where we can play with the ablation zone a bit. However, you have to see whether it is a male patient versus a female patient. So under mesopic conditions, females usually have a little bit of a larger pupillary size as compared to males. So look at the gender, like I said, look at the amount of correction that you want to do. Also, blend zones are very important, especially if you feel the mesopic pupil is a bit larger in size. So you have to kind of play around with these 2-3 things and then decide what you want to do and how much of actually you want to correct. Sometimes, I have had patients like taken them to do a lenticule based procedure. I will not say which one, but due to a difficulty in docking the patient, I had to convert to an excimer, and I had to tell them that I'm going to do a surface ablation, but I might not be able to correct what I was going to correct with a lenticule. Right. So, and then the haze, then you have to explain that with a higher correction, there might be some haze coming in just because of that docking part. So there are things that you can just think on your feet and then correct. But yes, like I said, in any and every surgery, you have to do the scans preoperatively, you have to do the due diligence preoperatively. There can be no rushed at the last moment thing in these surgeries, because even a small confusion or a small error can cause a lot of problem to the patient later on, because these are just end procedures. There is no reversing these procedures. So we have to think and then decide.
I would also like to ask Dr. Amita, what's your take on starting steroids right immediately post-op in PRK or surface ablation procedures? Most European papers and journals, they discuss withholding the steroid for the initial 24 hours and first starting off with the antibiotic and then later on shifting to that. So in our scenario, in Indian scenario, what is your experience vis-a-vis starting the steroids and antibiotics on the very next day, or you withhold the steroid for a day or two?
Okay, see, Kanika, it is a very individual preference, I believe. I really don't think it makes the kind of antibiotic cover we give to the patients, the kind of fourth generation fluoroquinolones we give. I don't think it makes much of a difference giving steroids. Plus, the BCL is kind of already, it is a sterile thing that we put on top of the eye. If the patient is maintaining their hygiene well and using the antibiotics the way they are supposed to use them, I don't think it creates any additional risk for the patient. However, that having been said, I have worked with surgeons who used to discourage use of steroids for the first 3 days. They would only start the steroids once they would remove the bandage contact lens. So it's an either or question. However, I feel if you have corrected a higher amount of error, you may as well start with the steroids. You may start with fluorometholone if that makes you sleep better at night instead of using prednisolone acetate, but might as well use, because then you'll have haze staring you in the face some weeks later, and I don't think that would be a really good outcome for the patient. So you have to just balance it out. Low corrections, yes, you may let go of the patient for 2-3 days, it's okay, but then moderately high correction, yes, I would like to use steroids from day one itself.
Yeah, so generally we also follow the same norms. We do start the steroids, and as an additional prophylactic measure, sometimes we also start the antibiotic prophylaxis 2 days prior to the procedure. So that helps, I guess, and we can right away. Do you prefer fluoromethanolone in your post-op patients post-surface ablation, or do you prefer the higher, stronger prednisolone steroid in your post-ops?
I usually give prednisolone, but I can tell you for a fact that if you got to use it for a longer period of time, and if again the correction is not of a very higher order, you might as well use fluorometholone. That's okay. There is, in my experience, there is not much of a difference between the two. However, you have to taper the steroids over a long period of time. So for me, at least, I use for 8 weeks post surgery. So people usually taper them off in 6 weeks. I use till 8 weeks.
Okay. And we've also seen that there is this case of people who are steroid responders. So in case when you're starting and tapering it off for a longer duration, have you experienced steroid responders in your way? And how do you tackle steroid responders when you want to give anti-inflammatory therapy for a longer duration in such cases?
So, see, that is when you have the NSAIDs, but I have had to discontinue steroids in a few patients, not in a lot of patients, but I have mostly gotten away with changing my prednisolone to my loteprednol, right? So I have always managed to keep them on some lower form of steroid and then give them a longer taper. You can always put them on a anti-glaucoma medication if you think it is so warranted, right? You can always supplement it with an anti-glaucoma medication. Once the epithelium is healed, there is nothing to stop you from giving those medications that you feel will make the post-operative outcome better.
Yeah. Coming to the elephant in the room, what is your preferred method of epithelial removal in your surface ablation procedures? Like you mentioned about the microkeratomes, and you also mentioned about the epi blades, and then the various instruments we have for scraping and alcohol delamination. What's your preferred method, ma'am?
See, among all of those, I think nothing beats trans PRK. It's a total no touch technique, and you can give the patient maximum benefit. However, having used 3-4 different kinds of machines for ablation, I know that Schwind works beautifully. Again, like I said, I have no financial interest in that company, but the way it corrects using trans PRK, that is just like nothing I have seen. Again, with PRK, when you're using other systems, you have to shift from a you have to first do a PTK and then you have to shift to a PRK mode. Again, with PTK, there is no saying how much is the epithelial thickness. Okay, epithelium is not something that is very smooth over all the cornea. You don't know whether it's 50 at one place and then in the mid periphery it changes to something else, right? And when you are ablating a certain thickness. You cannot choose your ablation. Like you cannot choose to ablate differently at different spots according to how your epithelial map might be showing you. But then this Schwind Ameris, it integrates the epithelial maps and it exactly ablates the epithelium. And the beauty is that it first ablates the stroma and then ablates the epithelium. So I would probably give one arm and a leg for that kind of a thing. That is my favorite, definitely. But I think photorefractive keratectomy is a time-tested procedure. So I would go with the alcohol delamination any day.
Yeah, so
If
even
trans PRK is not available. Yeah.
lamination nowadays, it's more convenient and it gives the less drying time for the stroma for the undercorrection, overcorrection problems that we sometimes face due to the humidity levels and also overexposure of the stroma. Dr.
Correct.
Do we have any questions for ma'am?
Yes, ma'am, there's one question. And the question is, what is the name of instrument used in Epi-Bauman's keratectomy? The instrument used to remove the epithelium in Epi-Bauman's keratectomy is named as?
It is called as Epi-Clear. EPICLEAR. Epi-Clear.
Okay, ma'am. Okay, ma'am. And there's one more question. What is the duration of treatment? As in, what time should we wait to go for a advanced surface ablation in a case where we have aborted a primary laser vision correction?
That is a good
Some of
question.
the other
So,
cause, if we have aborted a procedure, then till what time should we wait for to go for an ASA?
see, that depends upon what procedure you have aborted at what step. Okay, so suppose it is a lenticule based procedure. Like, for example, if you have attempted a silk or a smile, and you have done the anterior and posterior surfaces have already been dissected, and you feel that you will not be able to go through because there is a huge black area in the middle and you'll not be able to dissect through it. So it is better to wait for a week or so, place a BCL, wait for a week or so, let the bubbles go off, start them on treatment, and then you can plan for a ablation, for a surface ablation. In a LASIK, I believe you need to wait till if it is a buttonhole or a if you've got a, depends upon where you have stopped. So if it is an incomplete dissection or it is a buttonhole, you need to again put a BCL, let it heal for some time, maybe a week or so, and then you can, as the cornea clears, you can go for a surface ablation. Okay,
You
ma'am.
just mentioned about herpetic keratitis and you mentioned that previous history. So, what is your take? If a patient who has a known history of herpetic keratitis in the past, although not too much of surface vascularization, would you take up the patient for a surface ablation procedure? And yes, if yes, and what would be your preferred duration of wait?
Okay, so uh, just one thing, just to clear, whatever vascularization, if it is a vascularized scar, say, or if the cornea itself is vascularized, because scar might not always be herpetic, but sometimes there are younger patients who do not know whether they have had herpes. So I had one of such patients some just a few days ago, and they did not know whether they have had any history of herpes, but there was a scar in the cornea which looked very suspiciously like a herpetic post-herpetic scar. So if it is in the periphery, like if it is outside the ablation area, I would go ahead with it. But I would give them a cover of a antiviral, like I mentioned, valcyclovir or even tab-acivir can be given. So you can give a pre-op cover for at least 2 weeks and then continue the cover post-operatively for at least a month or two. Right. So, but you have to explain to the patient pre-operatively that, it's not an absolute contraindication. But yeah, if there is a central scar, you would not want to go ahead with that surgery. Anything in the periphery, anything away from the ablation area, I would be okay.
Okay. There's a question again. A lot of people who have a history of adenoviral conjunctivitis or keratoconjunctivitis, they do have these nummular opacities on their cornea. So, are these patients good to go for refractive procedures, and is surface ablation an option for them?
So see, the thing is, Kanika, when you say nummular opacities, what are the nummular opacities? Okay, literature has shown that they are usually something we called as subepithelial infiltrates. Okay, you may try to give a course of steroids pre-operatively to reduce these. Okay, now if suppose you feel they are not reducing, they have been there for a long while, you can treat them the way you would treat corneal scars. Okay, and you may go for surface ablation, but again, the result will not be very good. Right now, depending upon if you want to go for a LASIK, suppose, say, so you can do, what you can do is, if the opacities are in the center, you can do an ASOCT, figure out what is the depth of the opacities. If they are in the center and they are in the superficial area and you do a surface ablation, you'll be able to take care of them. But you have to understand that the overall refractive error correction might not come out the way you have expected it to come. Okay, because once the epithelium remodels and those areas get cut, have they been like included in the, whether you have done a wavefront kind of an ablation or you have done a wavefront optimized or a wavefront guided, so that will be one thing. So it might end up more aberrated, the epithelium. However, at the same time, if they are present in a depth, you may just pick up a LASIK flap and then just ablate under that. In that case, the epithelium will still be the same, right? You're not changing anything about the epithelium. It will only be the healing of the nerves that might be affected in the long run, right? But depends upon where they are. So adenoviral keratitis, I feel I would just give a trial of steroids first for a period and then just see whether they are going away or not. If they are more central, I would like to explain to the patient that we may not get a very good post-refractive result, but we may still go ahead with the procedure.
So like you said, with a pinch of salt, yes, if the person or the patient who's undergoing surgery is too enthusiastic about it, probably with the due explanations about the post-operative complications and expectations should be there. A very simple question I would like to ask, what is your chair time with your refractive surgery patients in general? Do you explain everything in detail prior?
Yeah, so the thing is, I like to usually see the patients who come in for refractive surgery before dilatation once. So the norm in OPDs is usually the optometrist will see, optometrist will dilate, they'll work up and then they'll send them to you. So with me, it doesn't work like that. I usually like to talk to my patient while they're able to see my face clearly. And then I'd like to ask them questions about what they're expecting will happen after this procedure. Right, those kind of set the idea in my head that what my patient is actually, sometimes the expectations can be quite unfulfillable. So I tell them that this is not how it works. Right, so expectation setting is very important, and I believe it is very important if you're clear with the patient from the very first day. So you see them first, you understand what they want from the surgery, why they are getting the surgery done, and you ask them any history, whatever history, prior systemic history, ocular history, whatever you want to rule out, you ask them, note it down, send them out, let them get all the tests done. Once the topography is over, you can have a look at the scans and then explain to them what kind of procedure it is that they are eligible for, or what procedure would be safe for them, the pros and cons of those procedures. Then you give them time, you check them up, you post them for a surgery, but you give them some time. They need to so usually at clinics we have those brochures, or sometimes in some hospitals there are those detailed consent forms. Give the patient the brochure, give the patient the consent form, just let them read through it and let them come back to you with questions. I believe that sets some kind of trust between the doctor and the patient. The patient knows that we are not just out there just to do the surgery. We want the very best for our patient, and once that kind of trust is cemented, you can then tell the patient what is better for them and what. And but everything has to be explained, everything, whatever you're expecting, whatever the complications. So sometimes the patient may have very unrealistic expectation about what is going to happen post surgery, so that has to be explained. Expectation setting is important. My chair time is what you asked me, maybe anywhere around 30 minutes to 40 minutes per patient, especially if I'm going to do a refractive surgery and multiple sessions. And I usually give out my personal contact detail and tell them, please ask me whatever questions you have. It's always better to get everything out of the way first before you let the patient lie down on the.
That's true. And even through my personal experience, I feel that giving chair time prior to the surgery actually reduces the post-operative confusions and doubts and trust issues and everything. So very well presented, Dr. Amita, and it was a very extensive and detailed class. And I think everybody, even all of us, had a very good revision of all these procedures. Dr. Kritika, are there any more questions, or we can call it a day?
No, ma'am, I don't think there are any more questions. It was a very elaborately taken class.
Okay.
So
Thank you so
everything
much.
answered.
And
Thank
thank
you
you
so much. Thank you.
for the session with us. And unfortunately, Dr. Chitra ma'am could not be here due to some emergency, but very beautifully presented. So
Thank you
let's
so much. Thank you, Kanika. Thank you.
good
Thank
night.
you, ma'am. Thank you for the class. Good night, ma'am.
Night.
Good night, ma'am.